Ladies and gentlemen, healthcare policy is often discussed as if it's only about doctors, hospitals, and medical outcomes. But the real drivers of cost and access are frequently legal. Two major legal systems shape the modern healthcare market: certificate of need laws and health insurance rules and pricing structures. Together, they influence who can enter the market and how competition works, what providers charge, and how much patients end up paying. Tonight, I'm going to make a simple argument. Con laws and the structure of health insurance can both create distortions that raise prices and limit competition, and the direction forward should be fewer barriers to entry, more transparency, and payment models that reward value instead of volume. A certificate of need law requires healthcare providers to obtain state approval before opening or expanding certain facilities and services. The stated purpose is usually cost control, avoid unnecessary duplication, and prevent overbuilding capacity. But when the state becomes a gatekeeper for whether competition is allowed, the policy can produce effects the law never intended. Con laws can reduce competition. If new providers must get permission to enter or expand, fewer companies can challenge existing hospitals and providers. That can lead to monopolistic conditions in some areas, meaning patients have fewer choices and providers face less pressure to lower prices or improve efficiency. Competition is not a slogan in healthcare, it's a mechanism. When competition weakens, incentives change. Providers have less reason to innovate, streamline operations, or negotiate aggressively on pricing. Reduced competition can reduce quality incentives. When a market has limited entrants, there's often less urgency to maintain excellent service standards across the board. Even if providers are committed to care, the broader system becomes less dynamic. And in healthcare, reduced dynamism often translates to slower adoption of better technologies, fewer improvements in patient experience, and fewer reforms driven by customer-patient demand. Con laws can raise costs. If entry and expansion are restricted, prices can rise because providers gain more market power. Patients and employers then end up paying more for the same or slower growing services, since capacity adjustments happen through approval processes rather than market signals. The standard defense to this, con laws argue that states can coordinate healthcare resources better, avoid wasteful overcapacity, and ensure communities get what they need. That argument sounds sensible, especially when we imagine unchecked building and duplication. The problem is that avoid waste can become an excuse for avoid competition. In the real world, approval processes can be slow, discretionary, and influenced by incumbents who already operate in the market. If the system doesn't clearly measure whether a proposed service improves outcomes, lowers costs, or enhances access, then con laws become less about need and more about permission. A market can coordinate capacity without state gatekeeping. Transparency, reporting, and targeted oversight can address real capacity problems without granting monopoly protection by regulation. Health insurance. How can it increase the costs? Health insurance is designed to protect people from catastrophic expenses. That goal is legitimate, but insurance changes how costs are experienced and how pricing works. Insurance can distort sensitivity. When patients aren't paying the full cost at the point of care, they become less price sensitive. If the true price is hidden behind billing and coverage rules, providers have less pressure to compete on affordability. That environment can allow higher prices to persist. Administration adds real cost also. Insurance doesn't just reimburse care, it also creates paperwork, networks, billing rules, denials, appeals, and contracting overhead. Those administrative layers add to the total cost of care, and they don't directly increase medical outcomes. Pricing can become detached from value. Pharmaceutical companies and providers may set high prices when they know insurance will cover much of the bill. The result is inflated healthcare spending that grows from pricing, power, and reimbursement complexity rather than from medical value delivered. So even if insurance protects patients from disaster, the system can still generate high costs overall, costs that eventually reappear as premiums, deductibles, employer spending, taxes, or reduced access. The big policy choice is to eliminate or reform. There are three broad paths that we can discuss. Eliminating health insurance, removing insurance entirely would expose individuals to full cost. That might lower some negotiating pricing, but it would also likely cause delayed care, underuse of necessary services, and financial hardship, especially for people with chronic conditions or sudden emergencies. So no insurance is not a workable solution for a functioning society. Number two, reforming insurance. A stronger approach is to reform how the payment system works. Align payments with outcomes instead of volume. Improve transparency so prices and quality are understandable. Reduce administrative burdens. Strengthen incentives to deliver value. That means changing incentives so providers profit from better care, not from more procedures or higher charges. Number three, reevaluating con laws. Some states have already repealed or reformed con requirements, and the results vary by local market dynamics. That's exactly why policy should be tested, measured, and adjusted rather than treated as untouchable. If the evidence shows con laws restrict competition and raise costs without improving access or outcomes, then the policy should be reduced, redesigned, or removed. If there are truly narrow cases where oversight prevents genuine harm, then oversight can be targeted rather than blanket permission systems for expansion. The constitutional principle behind the policy debate, this is where con laws and insurance conversation connects with government power. When a state uses regulatory authority to block entry to markets, it changes who competes and how much power providers have. When insurance rules obscure customer costs, they shift pricing behavior. In both cases, government policy shapes the healthcare market structure. So the question isn't whether healthcare should be regulated. The question is whether regulation creates a system where incentives drift away from cost control and protected pricing. If we want healthcare that is more affordable and more responsive, policy should focus on reducing unnecessary barriers to entry so competition can work, targeting oversight only where it improves outcomes or access, not where it protects incumbents, reforming insurance incentives to reduce administrative complexity and reward value, ensuring transparency so patients and employers can make cost and quality decisions with real information. Con laws and insurance are both tools used carefully. They can help society manage risk and ensure access. Used carelessly or maintained as gatekeeping mechanisms, they can raise costs, reduce competition, and slow improvement. Real reform means changing incentives and structures so the system rewards better care at lower cost, not permission to compete less. That's the case for reevaluating con laws and modernizing insurance rules, not to weaken healthcare, but to make it work better for patients and for the families and employers who fund it. Thank you. God bless you. God bless Tennessee, and God bless America.